In the 1990s, the International Association for the Study of Lung Cancer experienced tremendous growth, and researchers were finding ways to advance care for lung cancer patients. In 1991, the 6th World Conference on Lung Cancer was held in Melbourne, Australia. Dr. David Ball was the conference president.
You have to remember in the period in which we did the conference, the only new electronic communications was fax. We didn't have email, and in the previous meetings, of course, they didn't even have fax, but most of the abstracts were submitted to us by fax rather than by mail, which had been slow mail, which had been the previous method.
Organizers were afraid people wouldn't travel because the first Gulf War started. Instead, the conference had more than 1,200 registrants from 47 countries. One of the speakers at the conference noticed the prevalence of people smoking outside the conference. His angry comments toward the delegates made the front page of the paper the next day. Dr. Ball also recalls a memorable excursion where delegates could take a train ride.
As part of a treat for the delegates, we organised for a group of outlaws, or as we call them in Australia, bushrangers, to hold up the train as it was passing through bush country before we got to our destination. So the train stopped, and out of the bush came these fairly unkempt individuals riding horses and firing their weapons in the air, and they bailed up the train, came on the train and asked everyone to hand over their valuables. And of course, some people who thought this was for real got a bit panicky.
In France, pathologists were discovering a new subtype of non-small cell carcinoma.
The major contribution in the pathology include the identification of new types of lung cancer, non-small cell lung cancer. In the early 90s, the identification of the basaloid carcinoma, and this is by Dr. Brambier group, in fact, and identifying basaloid carcinoma as a poor prognostic type lung cancer.
In the area of prevention, two of the most cited references emerged from workshops conducted to explore new options to intercept lung cancer. It was the first time scientists made the case for EGFR as an attractive target for prevention and treatment of lung cancer. 1993 was a busy year. The IASLC organized its first workshop on improving quality of life in supportive care. It was also the year there were advances in radiation oncology, immunotherapy, and epidemiology.
In the 90s, we went through numerous clinical trials, trying to better understand how to combine radiation and chemotherapy. Should given before radiotherapy, as I did in early 80s, or should combine with the radiotherapy together, so-called concurrent chemoradiotherapy. And what should give it afterward. So we went through a series of trials to explore the best option giving radiation and chemotherapy together.
And was there a conclusion?
And it turned out that giving radiation and chemotherapy together, so-called concurrent chemotherapy, appears to be the best strategy in terms of local control or survival.
Epidemiologists were studying particulate air pollution. They found there was an association between fine particulate air pollution and cardiopulmonary deaths. In 1994, the 7th World Conference on Lung Cancer was held in Colorado Springs, Colorado. The conference president was Dr. Paul Bunn.
The IASLC, of course, has a history, and one of the things that we did in Colorado Springs was to have a presidential reception for all the past presidents. At that time, fortunately, most of the presidents were still alive and were still attending the conference.
The conference had more than 1,300 attendees from 40 countries. Key social activities included a rodeo, a trip to the Olympic Training Center, and whitewater rafting excursions. The same year, researchers changed the way doctors treat small cell lung cancer and non-small cell lung cancer. Clinical trials proved cisplatin-based chemotherapy could prolong survival in non-small cell lung cancer. And in small cell lung cancer, the 2-drug combination of etoposide and cisplatin proved better than a 3-drug combination and has been the standard since that time.
Oh yes, I certainly feel that there is progress, and there are two, simplifying things, there are two domains, large domains of progress. The one is the patients with local and locally advanced disease, non-metastatic patients. The refinements that we have made in terms of diagnosis, staging, functional assessment, they are crucial in making the best choices of a multidisciplinary therapy, including chemotherapy, surgery, radiotherapy, combinations of these things. And there, the progress that we made in both the overall assessment and the therapy of the patient has certainly led to increased cure rates in these patients. We cure more patients with early and locally advanced non-small cell lung cancer than we did in the past.
Yet in the area of pathology, scientists looked at a series of surgically resected cases of lung adenocarcinoma.
In the late 90s, Dr. Noguchi's group published the subtype of lung adenocarcinoma, particularly the subtype of the bronchiolo-alveolar carcinoma that have 100% prognosis or survival after complete resection. And this actually have led to the subsequent concept that there is such thing as pre-invasive lesions of adenocarcinoma called the adenocarcinoma in situ.
A year later, researchers were looking at the value of positron emission tomography, known as PET.
And after CT, there was the revolution that came with the biological staging, but also the new imaging, the metabolic imaging of PET scanning, which again caused us to completely re-evaluate the algorithm we had for preoperative selection. And it took us a while to understand the way in which CT and PET could interact, and there were false positives and false negatives. So with all these new technologies, it takes a time for the pendulum to slow down.
The studies would conclude that PET was an indispensable component of preoperative staging for lung cancer.
In lung cancer study, further extended their studies to surgery itself. Dr. Robert Ginsberg at Memorial Sloan Kettering led the very important randomized trial between lobectomy and limited resection. The surgeons are always thinking what should be the most appropriate mode of resection. Lobectomy is enough, or lobectomy is too big, or something. So they have just tried to compare smaller resection and larger resection. The results was better for lobectomy, and this is also a landmark trial because ever since our standard mode of resection for cancer is lobectomy, it is still now. So in this sense, it's a very important study.
Also in the area of surgery, a new technique was developed to preserve the muscles around the chest. This Grunewald approach is still used today when surgeons need to extract tumors from difficult locations. In 1996, researchers saw evidence of immune response against cancer, yet the tumors grew in spite of the T-cell effects.
So it became clear in the later part of the 90s that there were some defects in the efficacy of the immune system that prevented it from becoming, it prevented it from attacking the tumor and effectively killing it. And so there were studies that started to define mutations in antigen processing and presentation machinery, such as the beta-2 microglobulin gene or the TAP peptide transporter. And those things were found in a very small fraction of tumors, but it seemed that a larger fraction, no specific defect could be found, that it had to be something regulatory.
In 1997, the IASLC held its 8th World Conference on Lung Cancer in Dublin, Ireland. Dr. Desmond Carney was the conference president. There were a record 2,500 registrants from 63 countries. The same year, the 5th edition of the TNM staging system was published. This new classification was presented at an IASLC workshop at the Brompton Hospital a few weeks ahead of their implementation.
Well, staging, of course, is a term which applies to the classification we apply, but it's also the algorithm by which we derive at a stage for a particular patient. And so there is the classification, but there's also the tools that we use to develop the stage in an individual case. And those tools depend very much on how far we have to go to create a clinical stage at a point where we are then able to decide the appropriate treatment for a patient.
Staging was also being advanced by pulmonologists who were using a tool called the endobronchial ultrasound, or EBUS.
The other step was the introduction of ultrasound, and the ultrasound is possible to use this technique through the bronchus way or through the esophageal way. And one important point is the possibility to perform the transbronchial needle aspiration guided by the ultrasounds. And this allows us to better stage the mediastinum. The mediastinal staging is one of the goal of the new staging system, and to be able to stage the mediastinum with a semi-invasive technique is obviously better for the patients.
There were yet to be any randomized trials with CT screening, and the search for biomarkers continued. In the late 1990s, researchers were looking at the psychosocial aspects of lung cancer, specifically depression, and there were developments for the management of breathlessness. These were just a few examples of great scientific strides in the 90s, and change was happening at the IASLC too. Membership increased from about 650 to 1,500 people during the decade. Members were quite equally distributed between Europe, North America, and Asia and Australia. It was certainly a time that researchers found ways to advance care for lung cancer patients.